My pleasure to join my colleagues in Abu Dhabi and Dubai and the United Arab Emirates. I had great memories there, and I still have lots of friends. And inshallah, we'll always meet and share what we know and what we learn and help each other. I'd like to thank Dr. Tawakkul and Mr. Muwaffaq, who I've known for a while, and the organizing committee for inviting me to your very interesting conference, which I've actually listened to many of its lectures. So they're actually very informative, evidence-based lectures. And I hope to continue the tradition in talking today about jaundice and the new nomogram and some things that will happen probably in the very near future. So again, greetings from Children's Hospital of Nevada. And our objectives today is to discuss one case scenario, or more if we have time, about jaundice, review risk factors, and how do we manage this case, and the new nomogram, which will go into some more details because it will probably be the standard of care in the very near future. How do we use phototherapy and the AAP recommendations for management of jaundice? So we always start with the baby, and we do have a baby C. He was born, it's a real baby actually, on 4/2/2017 at 1839 at 38 5/7 week. So the gestational age is important. The delivery is by vaginal birth after C-section to a 23-year-old mother, G2, P1. Good Apgar score, weight is 3.5 kilogram. The mom is O positive, so all O moms their babies get tested. So the baby is B positive, Coombs positive. Hemoglobin is good, 18.6, and retic is 3.5%. Baby is breastfeeding. So because baby has positive Coombs test, we do bilirubin. So bilirubin at 12 hours was 6.9 milligram per deciliter. And at 24 hours, it's 8.7 milligram per deciliter. Baby's breastfeeding well. He has 7 wet diapers over the first 24 hours. I calculated the rate of rise for you. It's 0.15 milligram. But we have this 8.7 milligram in a Coombs positive babies at 24 hours. So what would you like to do? So as pediatrician, we should be able to say, okay, this is what I want to do. Now, if I ask the junior doctors here in the hospital what to do, they will take out their phones and they will look into one of these apps or websites. This is billytool.org. This is BillyRex from Stanford, where Dr. Butani is now. This is BillyCalc. This is MDCalc. All these apps, what they will do is they will ask you either to put the time and date of birth and the bilirubin level, or the age in hours with the bilirubin level. And all of them, what they will do is they will plot these numbers for you in the graphs included in this guidelines. This is the guidelines from AAP from 2004. It has not been updated since then. And it's kind of more or less the standard of care for jaundice in most countries in the world. I'll show you what we do in England, or what the people do in England with their own guideline. However, what I do is I just have the 3 graphs on my phone, so I don't have to go to any websites. And these are the 3 famous graphs from the guideline. The one on the top left is the nomogram. This is the Butani nomogram. And you can see it divides babies into 4 different zones. This is the management of phototherapy. This is the management of exchange transfusion. And it divides babies into 3 lines: high risk, medium risk, and low risk. So you can plot them yourself as well. In the NICE guidelines from England, they have a interesting because an interesting way to check for jaundice, because they do it by weeks. So they have every week has a line for phototherapy and a line for exchange transfusion, and they start at 23 weeks gestation. So it's very helpful if you have a premature baby, because the guidelines from AAP is 35 weeks and above. It does not tell you what to do for preterm babies. And we'll stick with that because that's most of our population, is babies who are late preterm and term. So when the guidelines came out in 2004, and we saw the two graphs for management with phototherapy and exchange, and they have 3 lines for 3 risk levels, I actually made these graphs, and I made 3 graphs, 1 for each level, and when to start phototherapy, when to do an exchange. However, you needed to decide what level of risk the baby is on. So this is medium risk, this is low risk. So that requires a little extra work. So let's go back to the Nomogram from Dr. Bhutani that was published in 1999. And I will plot the baby for you. So this is the baby at 24 hours. So he is in the high risk zone. So we need to know first, high risk for what? Because we'll talk about risk in the other graphs as well. And this is a population graph. So this is 40th centile, 75th centile, 95th centile. And we'll go into a little bit more details about the nomogram itself later. So the baby is in the high risk zone, and the graph itself does not tell us if the baby needs phototherapy or not. To find out about that, you have to go to the phototherapy graph. So this is the guidelines for phototherapy, and I plotted the baby for you at 24 hours, and the baby is here. It's between medium risk and high risk. So what risk line is this baby for this particular graph? Okay, if you remember, they actually identify the risk levels here. So medium risk, which is the big dashes, is 38 weeks, which this baby is, 38 and 5, and has risk factors. So the risk factors are mentioned here. So these bullets are very useful, and we should all read them. So isoimmune hemolytic disease with a Coombs positive test, that's a risk factor. So that makes this baby a medium risk. So officially, he does not meet criteria for phototherapy, okay? But it's good to read the bullets, because in the last bullet, it says it's an option to provide conventional phototherapy. So we'll talk about phototherapy, what's conventional and what's non-conventional. So baby did not meet phototherapy, but did not receive phototherapy. Mom stayed for 48 hours. So we checked bilirubin again at 48 hours, and it was 12.3. So we have 8.7, went up to 12.3 at 48 hours. The mom is going home now. Now, what should we do? Should we, normally, the usual thing is, okay, let's plot him again. So again, let's go back to the nomogram. So this is the baby at 24 hours, and this is the baby at 48 hours. And you can see that babies don't stick with their zones they start with. So the baby moved from the high risk to the high intermediate risk zone. Okay, again, this graph does not tell us whether we should treat the baby or not. This is the one that does. So this is at 24 and 48. The baby is still below phototherapy line. So, but mom is going home. And remember, we said it's an option to provide conventional phototherapy in hospital at levels 2 to 3 milligram below those shown in the line. So this baby was within 2 milligrams of the line for phototherapy. So it was an option to actually go ahead and start phototherapy. However, the doctor who was taking care of the baby decided that he did not meet phototherapy criteria and kept the baby in the hospital. And mom went home because they needed the bed. So baby stayed in the hospital, and at 72 hours, bilirubin was 13.9. So the rate of rise is decreasing. At 3.5 days is 13.6. So the jaundice is actually coming down. So his pediatrician felt comfortable sending him home. So he said to the mom, take the baby home and come see me in office the following day, which was Friday. Mom didn't go, and she noticed that on Sunday that the baby was much more jaundiced. She brought the baby to the emergency room, and the bilirubin was 18.6. Hemoglobin dropped from 18 point something to now 14.8, but the retic is okay, came down. Slightly high for 6 days, but not bad. Baby's breastfeeding well. He has 6 to 7 wet diapers, 3 stools, and lost about 400 grams. So now what would you like to do? We're now day 6, bilirubin is 18.6. So we can plot him again. So let's plot all the numbers that we've had over the last 6 days. You can see that the baby went from high risk, high intermediate, low intermediate, back to high risk zone again. So babies can move. This is the nomogram that is just population numbers. These are the values of the babies in the general population. Dr. Putani had 2,840 babies. He was in Philadelphia at the time, so large Black population. None of these babies in the nomogram had any hemolysis, or at least any known hemolysis. No blood group incompatibility, no known G6PD, or no known spherocytosis. So these are babies without other risk factors. So, and like we said, it doesn't really tell us what to do with the numbers. It does not tell us when to start phototherapy. So what is the value of the nomogram? Why do we need to use it? This is the Kernicterus registry, and over about 11 years, they collected 111 cases of Kernicterus. This is probably underreported. Estimates are 1 in 60,000 to 1 in 100,000 live birth may have Kernicterus, and that's in advanced countries. So Kernicterus is a devastating disease. It's horrible for the child who has it. It's a lifelong problem. So the parents of these children came together and formed a group. They organized themselves into an organization they called PIC, Parents of Infants and Children with Kernicterus. So, and they said to their doctors, now my baby or my child has this horrible disease. Could this have been prevented? And the answer is yes, it could have been prevented if we detected that the bilirubin was high. And it can be like reason the treatment is very much available, whether phototherapy. So we do phototherapy to avoid doing an exchange, but if push comes to shove, yes, we can do an exchange transfusion. So they looked at, they actually lobbied people, and they made it a never event, and they Institute of Medicine, the Joint Commission made it a sentinel event if the baby has severe hyperbilirubinemia. So they said, okay, how can we prevent Kernicterus? So they looked at the cases who had Kernicterus confirmed, And I covered the causes of the top 6 causes for the kernicterus here, just to see how, if we can guess what the causes are together. So the most common cause with the 39 babies who all had very high bilirubin, like 20.7 to 52, with a mean TSB of 36.7 milligram. These are very high bilirubin. All of them had very high bilirubin. So if we identified the high bilirubin, they could have had an intervention. And some of them, this is not necessarily the maximum bilirubin. This is one measurement of bilirubin. So can you guess what is the cause of the most number of babies with kernicterus? Is it RH incompatibility, ABO incompatibility, other blood group incompatibilities, or is it possibly other hemolytic diseases? I remember I mentioned that, and I know it happens also in the Emirates, that when mom is O or RH negative, we check baby's blood type. So after they investigated these cases, the most common cause was idiopathic hyperbilirubinemia, which means that after they investigated everything, they ran all the tests, they could not find a reason. So these babies who had the most numbers or most contributions to the kernicterus babies had either some factor we don't know, or a group of factors combined together resulted in this high bilirubin, and this high bilirubin was missed. You can see that there's not really much of a RH incompatibility here. This includes all kinds of hemolysis because we monitor them. So if a baby is born to RH negative mom, we know, and we keep an eye on the baby. If the baby's Coombs positive, like this baby that we had, we keep checking their bilirubin. And so we keep a close watch on them. It's the ones we don't expect are the ones who can get into trouble. So how can we find these babies? How can we find these babies who do not have a clear factor or specific one that we know that causes kernicterus or causes very high bilirubin? Is it possible that by measuring the bilirubin levels during the hospitalization, we can identify those who are running much higher level than the regular population? So these are already at a higher risk for having severe hyperbilirubinemia. So these are the risk zones, are actually identifying the risk to have a bilirubin above 95th centile for this population, or what we can use as or call risk for severe hyperbilirubinemia. So by dividing it into 40th centile, 75th centile, 95th centile, we have an idea on what is the risk for this baby to develop severe hyperbilirubinemia. And maybe then we can monitor this baby closely. So if the baby is in the low risk zone, less than 40th centile, there is zero chance that he or she will have a bilirubin above 95th centile. If the baby is in 95th centile, it has 40% chance of staying above the 95th centile. So we're not positive that that's what will happen to the baby, but this is a baby who warrants close monitoring. Now, remember the Bhutanese Nomogram, all babies did not have incompatibility. Nobody had a Coombs positive. So what happens if our baby is Coombs positive? Where can we plot the baby for the Nomogram? So in this study from 2010, what they did is they had Coombs positive babies and Coombs negative baby, and they plotted them in the Bhutanese Nomogram, and in the low intermediate risk zone, 3% or one baby. They have very few babies in this study. So having a Coombs positive increases your risk of having severe hyperbilirubinemia if you are in the low intermediate risk. If you're in the low risk zone, nothing happens to you. You're still safe. So, however, it varies by population, how many will go on to develop severe hyperbilirubinemia. So it's important to know your population. So with this, the guidelines or some of the hospital's guidelines were that if you're in the high risk zone, you either delay discharge, start phototherapy. Some people will say, okay, let's send them home and check again in 12 hours. If you're in the high intermediate, that warrants a check in 24 hours, low intermediate, 48 hours. And this is just some suggestion from some of these studies to convert the graph into something usable by the pediatrician. So the nomogram has its limitation and its benefits. So in the middle of last year, this study was published from Utah. The first 4 doctors are in Utah, and then Dr. Bhutani, he's in Stanford, and they used them with their study because they compared their nomogram to the Bhutani nomogram. However, they had the major advantage that there were a hospital system with 20 hospitals. And they started, once the guideline came out in 2004, by 2004, 2005, they made it a mandatory to have every baby born in their hospital systems to have a total serum bilirubin measured before discharge, preferably after the first 24 hours, but they had lots of babies before the first 24 hours. So they had 15 years of data from 20 hospitals. So Bhutani's nomogram was based on 2,800 babies. They had more than 420,000 babies, or data point, total serum bilirubin. They excluded, again, the hemolysis, the babies who are Coombs positive, the babies who had spherocytosis. So they ended up with 397,000 total serum bilirubin values. So now they have a lot more data than the Bhutani nomogram, and they can even divide them into subgroups. So this is what the nomogram looks like. So it's much smoother than the Bhutani because we have so many more data points to check. And if you noticed, the start is a little bit high, but they have more data in the first 12 hours of life than the Bhutani nomogram. And then they looked at their population. So again, Utah is also kind of more white than other states in the United States. So you can see here, the white population is 81.5. The Black babies born in their hospital system is 0.7%. In the United States, whites are about 63% and Black is about 12%. So Utah is a very white state. However, there are Hispanics, there are Asian, there are Pacific Islanders, Black, natives. So many racial groups. So this is good because it makes it a little bit more generalizable than other nomogram, which we'll look at soon. They also, because they have so many babies, they could divide them by weeks. And even in the lowest number, they still have like 3 times what the Bhutani nomogram had. They had males and females, and as we actually should expect, males are 51% of the newborns and females are about 49% of the newborns, because that's the normal distribution there is. And they did not find a difference between boys and girls in terms of bilirubin, because it was suggested that girls may run lower bilirubin, but they did not find that. So when they took their nomogram and they imposed it over the Bhutani nomogram, this is what they got. So it's a smoother line. they start a little higher, and this is mostly Asian babies, and Asian means East Asians. So East Asians start with a higher bilirubin level, and Black babies start with a lower bilirubin level. They have a wider range because they have more babies, and so their 95th centile is also a little wider. So, but all in all, it's pretty close. So it follows the same pattern, except it plateaus a little bit later than the Botany nomogram. And they think that's because the Botany nomogram had more Black babies, which get rid of the bilirubin a little bit faster too. So their plateau happened around 6 days, and they start with more data points so we can do that. So the idea is, now we have high risk, high intermediate, low risk. That gives us the babies who are at risk of having a bilirubin level that's higher than the regular population, because these babies have some issue. However, again, this represents the population in Utah. So different countries went ahead and did their own nomogram. Actually, Japan did their own phototherapy graph. But these countries did their own nomogram: Italy, Taiwan, China, Japan. Obviously, like China, Japan, Nigeria may have a very uniform racial distribution, or one race mostly. So they may not apply to everybody, while the United States having multiracial society is probably better. And some of these countries have, they have 2 different or 3 different studies with 3 different nomograms. But many countries did their own nomograms. And the important part is to worry about whether we should use transcutaneous bilirubin versus serum bilirubin. Serum bilirubin is more accurate. However, it's a lab test, it's a blood, it's cumbersome. Transcutaneous is, the machine is expensive, and there has been issues. It depends on what the manufacturer is. And there has been issues with dark-skinned babies. So Black babies, is not as accurate with the transcutaneous bilirubin. If you want to develop your own nomogram, there is a very good study from Italy on how they developed their own nomogram, and they explained the statistics and how they took their samples and how they did their population distribution. So this would be a good place to start to form your own nomogram. So now let's go back to our baby. We showed you how he went from high risk, high intermediate, low intermediate, back to high risk again. My guess is that when the baby was kept in the hospital, the baby had nurses feeding him. So the nurse fed him formula probably, and if we said baby should take 55 ml, the baby took 55 ml regardless of whether he wanted it or not. This is the phototherapy graph now, and this is easy to follow since it just tells you if your number is above the line, then you should start phototherapy. So you can see baby was below medium risk line, and then he went above the medium risk line, so he deserves phototherapy, or we should start phototherapy. And if you use the billytool.org website, it will not plot the baby for you in the exchange. It will tell you if the baby meets phototherapy criteria or numbers, you go plot him on the exchange yourself. So we did that, and he's way below exchange. So baby needs phototherapy. So should we start quadruple phototherapy, or put the baby in the sun, maybe early morning or late afternoon? Or should we give the baby extra water? What would you advise the mom? So think about it a little bit. I know the sun, obviously, is how phototherapy was discovered. So Then we figured out how phototherapy works. So the most important thing, or one of the most important things to remember, is that phototherapy is not ultraviolet. This is the wavelength of the white light or visible light. Up here, beyond here is infrared, here is ultraviolet. And the more wavelength, the more skin penetrance and the less energy. The energy from the light, which now converts bilirubin into lumirubin, which gets excreted in the urine, this energy is measured, it's called irradiance, and it's measured in microwatt per centimeter square per nanometer. The most effective area is the blue-green wavelength. So this is the most effective part. Obviously, white light, which encompasses all this range, will work great, okay? However, to maximize the effect of phototherapy, this is the irradiance as it goes up in numbers, and this is the percentage decrease in bilirubin. So as you increase the irradiance, the bilirubin gets excreted better until you hit about 30 to 35 microwatt. Then it doesn't pay to increase your irradiance over that. Important to expose the baby properly, use proper light and appropriate distance. If you put a blanket, that increases the exposure. Sunlight works, we know that because this is how it works. However, you cannot put the baby outside in the sun because the ultraviolet will give the baby a skin burn. So this is actually a Cochrane review from last year. They found 3 studies. Now they do what is called filtered sunlight. So because in low-income countries, to have this fancy phototherapy lights is very expensive and they have large population. So they actually do filtered sunlight. They build a glass house and they cover it with some film that prevents ultraviolet. And they put the babies naked inside this glass house. However, they have to have a fan because they can get heated. And one of the problems with sunlight is that babies can get hyperthermia. So if you have the resource, do not use sunlight. It's not a good idea outside. The baby will get sunburn. Inside in the house, it's not practical because you need sun rays directly on the baby's skin. So if you build your own glass house, it may get too hot in there. So if you need phototherapy, use phototherapy. So in conclusion, these are the guidelines from the AAP. First, promote and support successful breastfeeding and establish nursery protocols for identification and evaluation of hyperbilirubinemia. When you measure bilirubin, you can use either ones, and if the baby is jaundiced in the 24 hours visibly, you should check that. However, recognize that our ability to see jaundice is not consistent. It depends on skin of the baby, the light, how tired you are. And then we use age in hours to interpret. Most importantly, babies born than 38 weeks who are breastfed, especially first-time mom, are at the highest risk of developing hyperbilirubinemia. So these are the ones we should really focus on. And all these studies have shown that babies who are 35 to 37 weeks, which you do not keep in the hospital, you send home, who don't feed very well, mom is a first-time mom, they can have problems with bilirubin. As a pediatrician, you should assess the baby well and provide parents with what to do about jaundice and make sure they have good follow-up. If babies need to be treated, you should give them good phototherapy. Thank you.